So I'm going to give the final talk entitled IBAT Inhibitors in Clinical Trials. I'm a professor of pediatrics, a pediatric hepatologist at Emory University School of Medicine and Children's Healthcare of Atlanta. My disclosures, I'm going to highlight two of the companies here, Albireo and Mirum, because I'm going to be discussing clinical trials using two of their compounds. Our first question, and only question here, what are viable short and medium-term primary outcomes for IBAT inhibitor trials? And here, just like some of the other questions, you can select as many as you think apply. Please begin your voting. Great, thank you, James. And yes, thank you for the reminder about submitting questions. It is a bit complicated on some people's interfaces, so please persist. Thank you. So here are the results, viable short and medium-term primary outcomes for IBAT inhibitor trials. Nearly everybody wants to see or believes that a reduction of pruritus or reductions of serum bile acid levels. That's fantastic. That really helps me as I go through the rest of this talk. But also about half of us think that there should also be a reduction of liver bile acids, reductions of ALT, and I would argue that that would mean other parameters that we can readily measure, and perhaps the most important one, which is survival. Okay, thank you. So our learning objective for this talk is you'll be able to identify completed and ongoing trials for the use of IBAT inhibitors in various liver diseases, and you'll be able to recall the results of clinical trials, including efficacy, and some safety data that we can share. So I want to frame clinical goals of IBAT inhibition by starting on the right-hand of this slide. And I really bucket this into three different questions. Which diseases, which stage of disease, and which primary outcomes, which on the surface we would always think that there's an easy checkbox here, but there truly isn't. But I think we're going to get there and start to identify answers to each of these particular questions. I also want to say, what are our desired outcomes? And I argue that I believe that one way that we can make cholestasis better is really get to the root cause of cholestasis. And we've never really done that. And here we would try to improve the hepatic adaptation. And if cholestasis is an aberrant accumulation and response to bile acids within the liver, we want to reduce the total bile acid pool, and we want to reduce the accumulation in the liver. But we want to have a result, and clinically, the most relevant, and we heard this from Dr. Looms, that we want to have a decrease in pruritus and also have an improvement in survival and quality of life. So as of a few days ago, there are 26 studies in clinicaltrials.gov that talk about IBAT inhibitors, and involves any one of these 5 compounds that I'm showing you here. Of the diseases that are listed on the right, there's Alagille syndrome, PFIC1 and 2, biliary atresia, PBC and PSC, NASH, and a variety of other diseases. The check marks here in green really only relate to the peer-reviewed publications. And there are 2 on maralixibat, 1 on volixibat that we heard from Dr. Sanyal, and 1 on linerixibat. But the way that the field is now going, there's a lot of information on 2 of these compounds that are in trials or trials that are being planned, and that's odevixibat as well as maralixibat. For those of you who are at the late breakers, the paint is still a little bit wet on these studies, and they've just presented preliminary results on these, and I'm going to share some of these as well. So we're going to focus on these 2 compounds. I also want you to notice the shape of the molecules. These are very big, bulky molecules. This is why they don't get absorbed. So there's an attractiveness, at least in my mind, to try to see that is there a medication that we can give that just doesn't become part of the metabolic milieu within the cells and within the liver. And so something that is luminally restricted has some attractiveness. So on to the studies. Here's the only adult study that I'm going to share, and it's called Clarity. It's maralixibat, 13 weeks in PBC. It's a phase 2 study. The patient characteristics on the left are as you anticipate, 53-year-old, mostly female. They had the ItchRO scores, which is a patient-reported outcome for itchiness going from 0 to 4, and they sum them up over the week. They had high alphosphorus and mildly elevated serum bile acid levels. On the right is the results of the change in ItchRO score from their weekly sum from the beginning baseline up to week 13. And what you see in the open circle symbols is placebo, and in the shaded symbols are either 1 of 2 doses of maralixibat or a combined both doses of maralixibat. And as you can see here, they're virtually indistinguishable curves. And this is something that I think is an interesting and relevant point in these studies for pruritus. And I'm highlighting the placebo group. And you can see that 13 weeks on placebo, people report less itching. And this is a feature of many of our studies, that there is a high placebo response rate. So this is going to be incorporated, and perhaps we can get into this in the Q&A session. So this is an issue that we're going to have to continue to deal with, especially if there are intermittent pruritic symptoms. In addition, due to the mechanisms of action, there's always a big worry about GI side effects or adverse effects. And these were incredibly mild, and in general, except for a few patients, stabilized quite well after an initial period. The next study is also maralixibat, but this one is in pediatrics. And this is one of several studies I'm going to talk about for Alagille syndrome, abbreviated ALGS. This too is for 13 weeks. It's abbreviated itch. Dr. Schneider just talked about this in the late breaker session. This is a much more cholestatic condition. Mean age is 6.8 years, serum bile acids of 200, high ALT, high GGT, total bilirubin of 5, high cholesterol. And the way this is presented as data, it's also the ItchRO score, and it's presented as better going down from top to bottom. And here the open circles are placebo, and these are 3 different doses of maralixibat, but certainly very small n's in each of the different dose buckets of between 6 and 12. And as you can see, there's a slight improvement perhaps in reported pruritus in placebo on the top. There was no difference at the highest dose of maralixibat, again, only 6 patients, but there seemed to be quite an improvement in several of them at the 70 and the 140 micrograms per kilo per day. An extension of this, as I mentioned, was just presented, and this seems to be persistent, meaning the improvements in pruritus seem to be persistent over time. The next study is also maralixibat in Alagille syndrome, and it's a really interesting and important study called ICONIC. And I'm giving you the bottom line where we reduced pruritus and serum bile acid levels. I'm going to give you the demographics of the patients first, and then I'm going to show you the data, which is easier to explain the study design. It's 31 patients, again, similar Alagilles, 5 years old. They're all jagged 1. It's a 48-week study, and an intervention happens between weeks 18 and 22. These patients had high ItchRO scores, again, 3, a maximum of 4, high serum bile acid levels of 280, bilirubins of 6, transaminases of 180, etc. So here's the results of the ICONIC study, and I thank the sponsors for sharing this, and this is presented by Emmanuel Gonzalez as well. And on the left-hand side is the similar reported pruritus, where improvement is going down. But on the right, for the first time, I'm showing you serum bile acid data. So I'm going to focus on the left, the pruritus scores. This is a study where every single patient started on maralixibat. So both the blue in the maralixibat ones and the red ones, they all started. But at week 18, those in the red line were changed from maralixibat to placebo, and those on maralixibat were kept on maralixibat. Obviously, this is randomized and blinded. 4 weeks later, those on placebo were returned to being placed on maralixibat just as they were before. And as you can see from this intervention, sort of intermittent intervention study, the pruritus worsened dramatically and rapidly only in those where the maralixibat was withdrawn and were on placebo, but it returned back to baseline, meaning they were improved in their pruritus, and they returned back to maralixibat by the end of the study here at 48 weeks. This continued, everybody's on drug, way up to 4 to 5 years, and a similar story is seen in serum bile acid levels. levels. Now, this is relevant because FDA likes pruritus as an endpoint. EMA is looking at serum bile acid levels as an endpoint. They both seem to correlate. Now I'm going to switch gears with a different drug and different disease. So this is a PEDFIC-1 study with odevixibat, just as Dr. Dawson said, IBAT is the end of it, which also has reduced pruritus and serum bile acid levels. And the disease here is PFIC-1 and 2 that Kathy Looms has mentioned. So here's a study that's 24 weeks in duration, where it's split evenly between placebo and 2 different doses of odevixibat, 40 or 120 micrograms per kilo per day. The entry criteria are, as you would expect, high serum bile acid levels to begin with, over 100 micromolar, high levels of pruritus, more than 2 on the 0 to 4 scale. So the top line results are presented here. I'm going to give you some extended data that's presented at this meeting from Richard Thompson at the next slide. So the top line data on the first bar graph in placebo, 28% of the patients during some time of this 24 weeks experienced an improvement in their pruritus by 1 point or more. But over 50%, here 53%, experienced that when on odevixibat. And only those on odevixibat reached their serum bile acid endpoint, which is a response of greater than 70% of their initial serum bile acid level, or to a level less than 70 micromolar. Well, this study has rolled into PEDFIC-1 into PEDFIC-2, and I'm going to share those results here. So the item on the left is a graphic representation over time of what I showed you as the data in the previous slide, where patients were given odevixibat in the light green mark, or placebo. This was for the entire time, not like the iconic and Alagille study. This is odevixibat in PFIC-1 and 2 for all 24 weeks. And you can see their pruritus was unchanged on placebo, but improved on odevixibat. At week 24, they were rolled over into an open label extension, where those on placebo on the top line were now on odevixibat, and they improved, and those that were already on odevixibat continued. This fuchsia colored or magenta colored line is a new group of patients who were never randomized, who were all placed on odevixibat with PFIC-1 or 2, and they too had improvements in pruritus. So these are very encouraging data. So I'm not going to go over this very busy chart. I just want to refer to a publication. We have this where you can see this in detail. What I want to point out is that it's a number of diseases with PFICs, biliary atresia, Alagille syndrome, and both odevixibat and maralixibat are really engaged in a number of studies in these diseases. So I want to end with a couple summary slides, and maybe this can be used to set the groundwork for our Q&A session. So again, these 3 bits of which diseases, I think right now we're talking about genetic diseases, well-defined, unremitting pruritus, which is just awful. For those of you who haven't seen it, it's among the worst things you can see in a patient where they just can't help themselves and there's blood on the sheets at times, etc. So it's really quite hard to see in a child. And so that's why the focus is on Alagille syndrome and PFIC-1 and 2. And I think sticking with our primary outcomes of reductions in pruritus and reductions in serum bile acid levels has legs. But what about biliary atresia, where these kids are not pruritic? Many of them have high serum bile acid levels. We really care about survival. Biliary atresia is the most fibrotic, the most cholestatic disease in all of liver, and it leads to cirrhosis within 4 to 6 months in many patients. So survival is really our issue. And so those who've undergone a Kasai procedure are able to be enrolled in a study that's open now called the BOLD study with odevixibat, and there will be another study with maralixibat with different criteria. But the primary outcome for the BOLD study is a clinical one, which is actual survival with native liver at 2 years. And I think that we look at these diseases, and I want to pick everyone else's brains about this, about diseases where there's retention of bile acids in the liver, and this is a way that we can get at the root cause. In adult trials, I'm out of my wheelhouse here a bit, but I'm going to do my best, and I'll wait for Dr. Sanyal to help with this. But which diseases? I think PBC and PSC, certainly when it's unaddressable endoscopically, et cetera, reductions in pruritus. But I think, as I pointed out with that one study, these are going to have to be very well-described patients with quite relevant entry criteria where there's a lot of itching, I would argue, or at least ways to track the itching. But there may be a way to make a composite endpoint with liver indices as well, which people have done for both PBC and PSC. There are scoring indices. Other cholestatic diseases like ICP, and as Dr. Sonyal said, I think NASH is a great disease. It may be that certainly an IBAT inhibitor in combination with other drugs that attack a different part of the NASH biology may be relevant. So before I get to a summary slide, I want to point out that there is a decent footprint of IBAT inhibitors at this meeting. And in green on the top are 3 studies I want to point your attention to for maralixibat. I mentioned already the Gonzalez study with Iconic. It's presented in more detail there. There's an analysis of the natural variability of pruritus and Alagille syndrome using the ITRO scoring with abstract 1792. And I mentioned the late breaker abstract from Dr. Schneider on Alagille. In addition, late breaker abstract was also presented in the same session by Dr. Thompson on PFIC 1 and 2. But in addition to those clinical ones, I want to talk about some other studies at the bottom here. There is still work on linerixibat and volixibat in phase 1 studies, but these 2 other studies are not clinical trials. And the McLaughlin one, at least from the abstract, is interesting because it's looking at a large database, and believe it or not, it's the 23andMe database, where they looked at patients who reported either gallbladder disease or colorectal cancer and looked at 2 loss of function mutations in the SLC10A2 gene, that's the IBAT gene, where these 2 very relatively common variants, and asked the question, are there more people with these variants in those that presented or reported gallbladder disease or colorectal cancer? And ends up being that these 2 variants, P290S and B98I, are slightly associated with gallbladder disease, but not associated with colon cancer. And they had 12,000 people who reported colon cancer in the 23andMe. That's not an appropriate study, of course. It's not definitive, but it's one way to start to get at the question of what happens when you reduce pharmacologically IBAT function. And lastly, although I pointed out 5 studies, there really are more targets for bile acid transporters, including not just IBAT, but other bile acid transporters. So in summary, I have the 3 overarching questions of diseases, stage, and outcomes. We talked about that, but I also want to add that there are likely differences in drug efficacy, that we're not approaching drug dosing, and of course, patient-specific responses. I do think on the left, as we talked about, the importance of cholestasis is to get at the root cause, reduce accumulation of hepatic bile acids with pruritus, and improve survival and quality of life. And I have 8 points really for key points, and I want to end on this before we get to the next point. 1, we really need to see the publications and dive deeply into the data on the PFIC and Alagille patients. There are some amazing improvements in pruritus in many patients, things that have never happened in their lives before. So this is something we need to pay attention to, but we need to see when it happens and how often. And are there also improvements in liver disease? Biliary atresia, as we mentioned, our #1 pediatric liver disease. There's an open study and there will be another one. This is absolutely relevant, and perhaps we can make an impact finally in that disease. Look for other IBAT inhibitor studies in NASH and PBC and PSC and ICP. GI side effects seem to be minimal and generally well tolerated. There are some people who have had to come off, but it's in general, it's well tolerated. But we really don't have long-term effects known on the colon. We need to see more data with larger patients. Caveats: pruritus is a difficult endpoint due to significant placebo effect. I think we will need to begin to really understand patient-specific and drug-specific responses. Roughly speaking, from the small studies so far in PFIC 1 and 2 and Alagille syndrome, upwards of half the patients really have a remarkable effect. Why? And finally, since we now can finally interfere with pruritus, we may be able to figure out pruritus. And I think that that's finally something relatively amazing in our field. But we are going to need larger studies, perhaps in the hundreds for arms or more, and longer duration.